What I hope to do in the process is to cover very briefly, how it all started, just by way of introduction. And then I'm going to deal with the epidemic across Africa and focus most of my effort on the epidemic in South Africa, ending off just very briefly on some of the vaccine research and development efforts in Africa. So just to kick us off and just to remind us about how it all started, and just as a recollection that we have already 4 coronavirus strains that circulate in the human population. To those 4 strains, just about 17 years ago or so, we added the SARS virus. And that virus came from bats and entered into humans through an intermediate host that's thought to be the civets. A few years ago, we had a second zoonosis from bats that entered into humans, also a coronavirus, that entered through camels as an intermediate host in all likelihood, and that was MERS. So this particular pandemic of COVID-19 follows in that trend. In this particular instance, it seems that the bat coronavirus, with which SARS-CoV-2 has about 99% homology in its genetic sequence, jumped from bat into humans. But it's unlikely it did so directly because it would not be able to infect human cells. So we think, and this is at this point evidence that's not firm, that the pangolins played a role in this. And the reason for that is that the coronavirus that was isolated from pangolins has a critical component, and that is the ability to attach to the ACE2 receptor. The angiotensin converting enzyme 2 receptor, known as ACE2 receptor, is critical. The ability of the coronavirus to attach through its spike protein to the ACE2 inhibitor is what makes all the difference. Suddenly, we have a virus with high affinity to a receptor on human cells. And it can use that receptor to enter human cells and cause infection in human cells. And this is what we have been dreading all of this time. But it also, I make this point to simply highlight that this is probably just one in many that could occur. And that if it occurred in this way, in this particular pandemic, it can occur again and again. So let's talk briefly about how is this virus that comes all the way from China impacting Africa. Well, so far we have just over 300,000 infections in Africa, close on to 9,000 deaths and several recoveries. If we look at Africa compared to the rest of the world, Africa is actually one of the less affected regions of the world. You compare that to Russia or Brazil or to the US or to India, where there are much more substantial epidemics. And within Africa, there's quite a lot of heterogeneity, with South Africa and Egypt bringing up the advance party and the other countries like Guinea and Kenya and Ethiopia bringing up the rear. We're not sure why there's so much of variation across Africa. It's not thought to be related to the introduction by international travel, because many of these countries, especially a country like Ethiopia, has substantial international links. So we're not fully sure why this is the case. Some have said, well, perhaps this is just about, they're just not testing. Well, that's not strictly true, because in many of the countries where there are not a lot of cases being reported, they're also not seeing a particularly large number or an rapidly increasing number of patients with respiratory illness. So it looks like there is a genuine variation between countries that are substantially impacted and those that are not. If we look at how this epidemic is unfolding in Africa, you can see from this graph how the epidemic is growing in each of the countries. And if we look at how this epidemic is unfolding, it looks like the epidemiology of this virus in individual countries in Africa also shows some variation. So let's look at the epidemiology in South Africa in some detail and get a better impression of what it looks like. So let me start off with something that's not always obvious to us, because in each of our countries, we're probably dealing with the restrictions and the stay-at-home orders or the lockdowns in our own way. And there's probably a lot of complaints and a lot of angst about how these lockdowns are impacting us, impacting our freedoms. And we're not always confident and not always clear that we're not the only ones. So let me show you how our world has changed in the last 4 months. And I'm going to do so by showing you a map of the world. The blue color shows countries that have no restrictions. The yellow shows countries that have some restrictions, mostly voluntary. The orange shows countries that have a lockdown, significant restrictions. And the dark orange shows that those are very strict lockdowns. So if one looks back to the 1st of March, what you see is that there are strict lockdowns in China and in Italy. India has a few restrictions and a few other countries in the East have restrictions, but essentially it's China and Italy. That's on the 1st of March. The 1st of April, the situation is different. So on the 1st of April, what we're looking at now is a situation where 86 countries have either national or subnational lockdowns. You can see that most of Asia is now dark orange. India, China, Russia. We look at Africa, they're starting lockdowns. And if one looks at the situation a month later, on the 1st of May, you can see now how this has changed. Much of Africa has lockdowns, and so too does Australia and New Zealand. So too does India and Russia. But China is easing its restrictions. We look at the 1st of June, and the situation is drastically different now. Now you have most of South America under restrictions. Africa, especially Southern Africa, is easing the restrictions. Australia and New Zealand have no restrictions. And China now has imposed restrictions again due to reintroduction and a second wave. And if we look at what's the situation most recently, this is what it looks like. So if I want to take you back to a very quick look at what the world looked like in 4 months. 1st of March, 1st of April, 1st of May, 1st of June, last week. That's how our world has changed. And while each of us in our own countries grapples with these restrictions, how it's impacting our lives, it is impacting the whole world. So let's look now at what happened when these restrictions were imposed in South Africa. South Africa declared a state of disaster when we had just a few hundred infections. In fact, it was quite a small number of infections. So we acted very early. First case was on the 5th of March, and within a matter of 10 to 14 days, the president declared a state of disaster. And then a few days later, he declared a national lockdown. The lockdown was imposed on the 26th of March. On the date on which the lockdown was imposed, the epidemic in South Africa was growing, roughly doubling every 2 days. We were on the same trajectory as the epidemics in the UK and in several other countries. So we moved from a situation where the epidemic was doubling every 2 days to doubling every 15 days under the lockdown 5 restrictions. So under the severe, strict lockdown that we had for 5 weeks, we slowed the spread of the virus quite dramatically. And as we started easing the lockdown into the next level, level 4 restrictions, we saw that the doubling time started growing a bit faster, down to 12 days. And currently, under level 3 restrictions, it's doubling at about 12 days as well. So this just gives you some impression of how the epidemic has changed just over this period, and the dramatic effect that the lockdown had was not just the lockdown, but the full panoply of restrictions that were imposed and their impact in terms of slowing the spread of the virus. And now we are learning how to use the full coronavirus prevention toolbox, not just the lockdowns, because the lockdown was just one extreme form of social distancing, but we are now focusing our efforts on changing our individual behavior, to introduce social distancing, hand hygiene, cloth masks, and so is everybody around the world. We are not alone in this. And as we think about what impact has this had, well, if you look at on the left-hand side, the cases of the infection, you can see, and I've put here for comparison purposes, the graphs for the BRICS countries. The BRICS stands for Brazil, Russia, India, China, and South Africa, which have a partnership known as BRICS. And I also chose to include 2 countries that have among the worst epidemics, and that's the US and the UK. And I've chosen 2 countries that have among the least worst epidemics, and that's South Korea and Australia. You can see that what's quite striking is that while most of these epidemics rapidly increase and then have this convex shaped decline, you can see that South Africa didn't quite follow that. And you can see the dramatic effect of the slowing down from a doubling of every 2 days to a doubling of every 15 days in the way in which this curve becomes somewhat concave. And that slowing down of the rate of which new infections occurred was key because it gave South Africa an opportunity to prepare. Prepare in terms of building field hospitals, prepare in terms of scaling up testing and all of the other important parts of the activities that were undertaken. And I'll touch upon some of them very briefly. If one looks at the deaths, it's a similar sort of picture, that the deaths occurred and rose much more slowly. But right now, we have an epidemic that's continuing to grow, and in fact, continuing to grow quite rapidly. And we always knew that was going to be the case because it is not really sustainable for us to have a long-term lockdown. There was going to become a point at which the lockdown was simply not going to be feasible to be a long-term strategy. And as we ease the lockdown and as we ease restrictions and people go back to school and back to work as they are now, we have to expect that viral transmission will increase. And as we look at that increase and as we look at how did it spread, what led to this virus growing in this kind of way? Well, I've just used one region to illustrate the point. And this is from the Eastern Cape region of South Africa. If we look at this region, in this area, the first case occurred on the 21st of March. And within a short space of time, by the middle of April, they already had outbreaks. There's a supermarket chain called Checkers, and in the city, the suburb of Walmer, the Checkers had an outbreak where 33 staff and the workers there were infected. In the Woolworths, another grocery store in Walmer, 18 cases. In a big chain that sells, a big supermarket chain called ShopRite, 36 cases. So while we were under the very severe restrictions, the one place where people were mingling was in the supermarkets and the grocery stores. And we started seeing small outbreaks there. There were also funerals, and the virus now was causing infections in funerals. One that was in Dwezi led to 44 infections. We also started seeing amongst the troops that were part of keeping control and the peace during the lockdown period. And then in some frail care centers, our big concern. So let me illustrate one example of how this virus can really get the better of us and how before we knew it, it had already spread. So a funeral took place in a little town called Zwidi, and in that funeral, there was a small outbreak. At the end of the funeral, after it had all been tracked, it was found that 10 people among those who attended that funeral had acquired the virus. One of those 10 happened to be a prison warder. When he went back to the prison, to West Bank Prison, when he became infectious, he then spread it to fellow warders and to inmates. And so before we knew it, there were 29 positive cases in West Bank Prison. But these warders all live in the West Bank community. And so they then took it back home and spread it in the community, and that led to 33 infections in the West Bank community. It happened that at the time, a family from another town, in Mtsane, was also visiting, and they became exposed and infected. So by the time we actually learned about this outbreak and were able to piece together the sequence of events, there's already over 100 infections because it had seeded into the community and was now spreading in the community. And that just illustrates what a challenge it is to slow this virus down, that it gets ahead of us so quickly, and how it can spread and use the opportunity of the way people mingle and interact to spread. So why is it that this virus is so difficult to stop? Why is it we have just struggled to stop the spread of this virus? Well, there are 5 reasons. The first is that people are highly infectious before they even have symptoms. It's in this pre-symptomatic period of about 4 or 5 days that people are infectious. And during that period, they have no idea that they have this viral infection. There are also those that are completely asymptomatic. They will not know ever that they acquired this virus, but they have been quietly spreading it without even knowing they have the infection. And it's spread through the 3 means that we understand well now. But I thought I would just illustrate one of them. That when we think about the way in which this virus spreads through contamination of surfaces, we know that it really doesn't survive very long on copper and on newspaper, on cloth. It really does not survive for any length of time. Within a few hours, most of the virus is dead. However, on stainless steel and plastic, the virus remains viable for 3 days, 4 days. It's a long period. In fact, when I was doing an investigation in our local hospital where there was an outbreak, as soon as I walked into the ward and I looked around and I saw the stainless steel everywhere, I realized the challenge of trying to get rid of this virus and to slow it down in that kind of setting. But it's in this particular way that the virus is able to survive for long periods and remain infectious. Some studies have suggested that contaminated surfaces may not be the most important way of spread, that it's a contributor, but that the more important way in which it's spread is through droplets, and that proximity is much more important than what you're touching. So we know it's difficult to stop this virus because of pre-symptomatic infectiousness through asymptomatic infectiousness, but also because it spreads so rapidly. Unlike flu, which has an R naught of around 1, this virus has an R naught closer to 2, and even between 2 and 3 in some instances. So that means just within a matter of days, you move from 10,000 people being infected to 20,000 to 40,000 to 80,000. And before you know it, you're on the back foot and this virus has become widespread. But you also get some super spreading events. And I've chosen here to just look at patient 31 in South Korea, that she went to a church service, subsequently went to a buffet lunch, then went to the hospital to have a test, and on her way back went to another church service before she was diagnosed. She exposed over 1,000 people. Hundreds became infected because of the transmission that occurred over the buffet lunch. So you can see that in a case like this, where the vast majority of people may be adhering to good control measures, just a small number can lead to a super spreading event. In the hospital where I did the investigation, one person, patient 0, who came into the hospital first for a swab because he had a sore throat and a headache and a fever, having just returned from the UK, that one person accounted for 14% of all infections in this particular part of the country. So it just illustrates to you that it's not just that it spreads, but that you have these super spreading events that make it really difficult to control. And even when you do control it, as has been the case in Singapore, for example, or South Korea, or China, you still have the big challenge of the repeated waves. Singapore for weeks had no infections reported. And then suddenly an outbreak occurs in their migrant hostels. As you know, Beijing last week was on lockdown because of new cases that had emerged. So you're always on the back foot trying to deal with this virus. So what do we understand about this virus? Well, when I first heard about it, described as SARS coronavirus 2, it was very much a case of this is a respiratory virus. Right? It causes sore throat, headache, and so on. Well, we now have a better understanding that indeed, in a proportion of patients, that you get a very severe immune response. So initially, the virus infects the nose and the back of the throat, where there are lots of cells with the ACE2 receptor. And in many of those patients, they'll simply overcome this virus, develop antibodies, and then move on. But a small proportion of patients, the virus goes into the lungs. And in a proportion of those patients where it infects the lungs, and in particular starts growing in the cells of the alveoli sac, that it leads to a severe immune response. It's referred to as a cytokine storm. And that cytokine storm leads to a situation where almost every part of your body is then affected in some way. Literally, and this article from Nature summarized it well. Every COVID-19 symptom we know about right now, from head to toe. Literally, it causes stroke, it causes confusion, it causes headache. So anything you want to know, it causes a lot of different features in the head, but it also causes COVID toes, little red blotches from the vasculitis and the bleeding that we see in the toes. So literally from head to toe. And if that wasn't enough, every week we learn about something new. So I chose just to share with you a set of papers that have come out literally in the last few days, each of them suggesting that the coronavirus may actually cause diabetes. Now, we already know that diabetics are at high risk of having a severe form of this disease, and they have a higher death rate. Well, it turns out that the beta cells in the pancreas also have the ACE2 receptor. And so the virus is able to infect and it's able to cause quite substantial damage in the pancreas and the beta 2 cells. And it can lead to creating a diabetic condition in patients. So we are learning something new all the time. So let's move on to what was the response to this virus in South Africa. Well, the response in South Africa comprised 8 stages. The first was when we were preparing in terms of establishing the testing, screening people coming in on travel. And then once we got our first infection, we knew that this was now real. This is not a disease affecting China and everywhere else. This is also affecting South Africa. And so we started initially with our primary, closed the schools, we stopped all international travel, and then we went into stage 3, which was our very severe, strict lockdown, where we focused on trying to lead to infections getting to a dead end so that they wouldn't spread to others because we limited the interaction between people. And then we started stage 4. Because South Africa has a very substantial HIV epidemic, and we have a very substantial program of community healthcare workers. Tens of thousands of community healthcare workers work on the HIV program to provide care. They know how to deal with infectious individuals. They already have a well-established infrastructure in the highest risk communities, the most vulnerable. And so very early on, we mobilized 28,000 community healthcare workers to go house to house and screen people for symptoms and to identify those who had one of the 6 COVID-19 symptoms to then go forward for a test. And they found to be positive, then were isolated and went through the processes of quarantine and so on. Once stage 4, which is currently just coming to an end, we started stage 5 a while ago. So these are overlapping. Stage 5 was about our hotspots, trying to identify where this virus is spreading and just trying to keep a lid on the outbreak so that we can flatten the curve, so that the number of cases don't increase too fast, so that our health system is not able to cope. And then stage 6 and 7, as we prepare for the medical care, we built field hospitals in most of the major metropoli in South Africa, and we've built up the ability of the healthcare service to cope with this. Increased ICU beds, increased our availability of oxygen supply, and so on, making sure that staff have PPE, that hospitals triage patients, all of the procedures that we would not have been able to do if we were dealing with this rapid rise in cases back in March or April this year. But we also recognize that we will see significant numbers of deaths. And so we're preparing for that. In addition, we are now putting in place the processes to ensure we have long-term vigilance to be on the lookout for the next waves when the first wave is over. And in dealing with this, we also recognize that as we go through the different stages of the response, on the one end is where you have the epidemic with the virus spreading, and you're trying to flatten the curve, and you're hoping you can get to containment, where you've got very low transmission. And then you can start living with the virus, coexisting with this virus by lifting some restrictions with mitigation measures until we get to a point, we hope, sometime in the future where we'll have a vaccine or cure and then have a very low threat. We in South Africa recognize that we will be living with this virus and that we will have to contend with the threat of this virus, probably at the minimum till the end of next year and even longer. South Africa, like India, Russia, and many other countries, is lifting restrictions while cases are increasing. That is, we are lifting restrictions without containment. So we'll always be in a very difficult position. Any actions we take could actually lead to an increase in cases. And so our main strategy now is mitigation with prevention and try and contain the outbreaks. And we're transitioning people from anxiety, because we know the initial lockdowns led to a lot of anxiety, to self-efficacy, where people now have to adopt the prevention strategies of washing hands and wearing masks and so on. So let me end off with some brief look at some of the vaccine research that's being done in Africa. So in Africa, we are monitoring our genetic variations of our strains. The 388 coronavirus sequences, full-length sequences we already have, indicate that we've probably had over 200 different introductions, most of which come from Europe. But importantly, we have seen that the spike protein has remained highly conserved. And most of the vaccines, of course, today are focusing on that spike protein. And if we look at our existing capacity, we have several countries with very substantial clinical trial capabilities. And if we look across the board here in the red shows the amount of resources that are being spent and the amount of research being done on preventive vaccines. So whether we talk about HIV vaccines, malaria, tuberculosis, and so on, we in Africa have been devoting substantial effort into vaccine research and development. And now we are going to make that capability available for developing the COVID-19 vaccine. But it's not just about vaccines and undertaking clinical trials. We also have to prepare for being able to manufacture them, make them accessible, ensure they're distributed in some kind of ethical way, and to implement mass-scale vaccination if we are to control and mitigate the impact of this. And South Africa has already started the first vaccine trial in Africa. It's the Oxford University vaccine that they've partnered with AstraZeneca, and that's currently being funded by the Gates Foundation and the South African government. Scientists from Africa have developed vaccines in the past. In fact, Clive and I are part of a group that have been working on studying acute infection. And as part of those studies, we were able to identify individuals that have broadly neutralizing antibodies. And we've developed one of those antibodies that's currently entering into human clinical trials for the prevention of HIV. So let me conclude by just summarizing that South Africa has indeed started flattening the curve. We've had no early peak. But this virus is now continuing to spread. So we're focusing on reducing community seeding from outbreaks. We're trying especially to focus on super spreaders as we try to flatten the curve. And South Africa is in that damned if you do and damned if you don't situation, now that we are easing restrictions while cases. So if you open schools, half the parents say, how dare you send our kids to school where they could get this virus and die? And the other half of the parents said, we got to live with this virus for the next several months, if not years. our kids better start getting back to school. So we have to shift our message, and we have to keep focus on the coming surge. And that message is really about self-efficacy, about protecting myself, protecting my family, protecting my community, a concept that's actually very familiar to South Africans, where we think about Ubuntu. Ubuntu is the concept that we are because you are, that we are part of the community. And so when I take protection, I'm actually protecting not just me, I'm protecting my entire community and my family. Thank you very much.
Thank you very much, Slim. That was a really great talk, and I think a great way that we can now begin to introduce some discussion into COVID-19, not only in South Africa, but in Africa. So one of the first questions that we had was the slow rate at which COVID-19 is progressing in Africa generally, perhaps even in South Africa and maybe Egypt. But is there, and your comments around this would be good, do you think there's some level of pre-existing immunity or some level of other vaccine cross-reactivity that may be conferring some level of protection, where we're certainly seeing case mortality rates at a much lower frequency than in North America, Brazil, or Europe, for example?
Yes, so there was some discussion about whether immunity to any of the other 6 coronaviruses that are in circulation, whether that has any protective benefit. So antibodies against them have not been shown to protect against this particular coronavirus. So that, I think if that occurs, it's in a very small proportion of people. A hypothesis was generated quite early on in the epidemic as to whether trained immunity may have some role, in particular the role of BCG vaccination, which I have some difficulty in trying to understand how that would occur, given that we give BCG at birth. And so to think something you gave somebody at birth is now going to be efficacious 40 years later through trained immunity is perhaps a bit of a stretch. But that hypothesis is being tested. There are several trials underway, including one in South Africa, of using BCG revaccination to look at whether it could have any impact. So I don't think there's any natural advantage or any immune advantage that we have in Africa. I think that there's sort of two natural, not natural, but there's two advantages we have by virtue of our state of underdevelopment. The first is that we do not have in most of Africa the kind of density that is central to rapid spread. We understand that density is key. And that was clear in the US, with New York and its very dense environment led to rapid spread. So we are seeing that now. The spread in Johannesburg, which is quite dense, is much faster than anything we've seen in the Eastern Cape, a much more rural part of the country. And so I think the fact that we do not have such density is an advantage. We do have some large cities. I mean, Lagos is an example, in Egypt and so on. So we do have some big, dense cities, but they are few and far between compared to what you will see in Europe and North America. The second is that there's a hypothesis that weather plays a role, and the extent to which weather impacts the virus, both temperature and humidity, remains unclear. I have to stress, it's only a hypothesis. There's no evidence. In fact, most of the evidence suggests that weather is not a major factor in the equation. I also think there's a third thing, and that's becoming clearer as we've looked at the US. And why is it we just haven't seen outbreaks occur among the Black Lives Matter demonstrators? We're just not seeing it. And it's thought that actually this virus doesn't do very well outside. Enclosed spaces, it spreads like wildfire. Put out into the sort of real environment out in the open, it doesn't seem to do that well. So whatever the reason is, I don't know, but I've given you some hypotheses about why that might be the case, that Africa has such a different trajectory than the rest of the world.
Mm. Yeah, it's interesting that you say weather, because another question is, do you think that vitamin D might play a role? I'm not sure what evidence there is currently, but it'd be interesting to know what you're thinking on vitamin D.
Yeah, I'm in communication with 2 or 3 scientists, one from Germany and 2 from the US, that have a very strong belief in the vitamin D hypothesis. And there's some biological evidence as well that's accumulating. I have a challenge with vitamin D because it's not easy to measure accurately. But I think that vitamin D is certainly something that we'll have to wait to see what the clinical studies show. I've remained agnostic to it as to whether it might have any impact or not. Because vitamin D will go with the confounder that I've already mentioned, which is if you stay outdoors most of the time, you will have more vitamin D, but you also have less exposure to viable virus. So it remains to be seen, what those clinical studies will eventually show.
Sure. Just changing tack a little bit, and one towards comorbidities for a lot of the patients that might be getting severe COVID and unfortunately dying. What are the common comorbidities in South Africa that we have in our data collection?
So in an analysis of just over 1,000 cases, we saw a very clear set of trends occur. And they actually corroborate what has been described both in China and in the US. So our number 1 comorbidity is diabetes, obesity, hypertension, malignancy, HIV, TB is much lower down the list. But those have been the most important comorbidities that we have found. We were not surprised to see those because those had already been described by the other countries. Diabetes, if you look at the attributable fraction of deaths, is around 56% of the deaths can be attributed to diabetes. So you can see it plays quite a key role. And of course, it goes with the obesity as well. And often those patients are hypertensive as well. So with these comorbidities, we have to recognize that, of course, our mortality is highest in patients who are older, as has been the case. And so these comorbidities are common in the older folk. And because they're older, we also see a much higher case fatality rate. I'll end up just on the note that the current evidence suggests that if HIV plays any role, it's a very small one. The attributable fraction is quite small. And the big issue there that explains that is that most of the deaths in COVID are in older people. And most of the HIV and the active TB from HIV is in the younger people, where we don't see many deaths. So HIV does not seem to be playing a major role as a comorbidity, creating an additional risk for death, which was a major concern for us. You can imagine in March, when I spoke to the minister, I said, we could be in for a disastrous situation. We have millions of people who are not on antiretroviral therapy yet. We've got to, we are sitting on a powder keg. If this disease, disproportionately affects immune suppressed individuals, well, it turns out actually immune suppression is one of the ways to treat this disease at a late stage with dexamethasone. So it seems that it's not a big issue. HIV is not playing a role as we thought it may.
Great. Another question is, what is the age difference between South Africa generally, the average age between here and countries in the north, for example, in Europe? And I guess the question inherently is asking about, is age making a big difference here in terms of the disparity between the COVID-19 trajectory?
Undoubtedly. When we look at our case fatality rates are substantially lower than the global average. And we think that that's largely a function of age. We should expect to see fewer deaths because we have a much more youthful population. If I remember correctly, it's something like only 3% of South Africans are over the age of 65. Don't hold me to that. I might not have the percentage correct, but it's a very small proportion.
Small fraction,
of our population that's over 65. The problem is that many of them are in frail care centers. So when the virus spreads in frail care centers, as we saw, for example, in the province where I live, the first 2 or 3 outbreaks occurred actually in frail care centers, in old age homes. And so when that happens, you really have a challenge because you see high case fatality rates. But in the general population, no, we see a much lower case fatality rate. And that's partly a function of our youthful population.
Another question that's being asked is about plasma exchange, or taking plasma for convalescent patients and using that as a kind of a treatment for people with severe COVID.
So we've initiated one such study in South Africa. It's being done by the National Institute of Communicable Diseases, being funded by the government, where convalescent serum is being collected. Exactly how it's going to be used in treatment is still under debate and discussion. We have not been enamored with some of the very early results that have come out from the US. But, you know, it's not something you can just sort of set aside, because the antibodies do play an important role. And the extent to which convalescent serum could assist in that regard, I think, is quite important. And so I think it's certainly something we need to continue to explore in the research. Ultimately, if convalescent serum helps us identify an antibody that provides us with very strong neutralization in a conserved epitope, I think that that would be a big positive for us. And so that's part and parcel of what we're also looking at.
Another question that's come online is your comments on the effects of hydroxychloroquine, azathioprine, and zinc as possible treatments. You already mentioned dexamethasone, so it would be very interesting to, I think, have your comments on that.
Sure. So if we look at, you know, when you think about the way in which the infection occurs, when the infection occurs initially, you are in the viremic stage. You basically have millions of the virus in your nose, in your throat. As you speak, the little droplets coming out are teeming with the virus. You sneeze, you put virus everywhere. So when you're in that viremic stage, a drug like remdesivir has a potential benefit as an antiviral, in that it can reduce the viral load, it can impact on the course of the natural response. And so an antiviral could have quite a significant benefit in that very early stage. A drug like dexamethasone will have no effect because you're largely dealing with the virus. In fact, no effect may not be appropriate. It might actually be harmful if you're suppressing an immune response that would naturally develop the antibodies. So dexamethasone is definitely not to be used in the early stages. When the virus gets into the lungs and we get the immune response, what happens is you get the pus buildup, and that blocks the ability of the oxygen exchange. Oxygen that you're breathing in is just not able to get into your bloodstream. And so your saturations drop and you're struggling now to breathe. It's not a mechanical problem. It's not that you can't breathe enough. It's you're breathing enough. You just can't get that oxygen through into the bloodstream. And so many patients do quite well just with oxygen support. And we have different approaches to giving them high flow oxygen, either through a nasal cannula or through a helmet. We have many different strategies to increase oxygenation. In fact, the supportive approach with just supporting them with oxygenation is critical, because just with oxygenation, we can probably lead to a significant recovery rate. Because once you get to intubation, in other words, once you have to mechanically ventilate somebody, our case fatality rates are very high. In our own setting, I think just over half of all our patients that we put on ventilators will not survive. That was the case in the recovery trial as well. In the US, in New York, it was 88% in a cohort of just over 1,000 patients. If you were put on a ventilator, only 1 out of 10 came off the ventilator alive. That's quite striking. It just tells you that when you get to that stage, you're so far gone with the immune response and your inability to exchange oxygen, and your saturations are plummeting at that stage. And so simple things like pulse oximeters are really important, because, as we've heard, many patients don't even know they have this disease. They have no symptoms. They just suddenly start realizing they can't climb up the stairs. They can't walk without getting short of breath. And shortness of breath, once you've got it, it has a quick progression thereafter. So we are learning about how to manage these patients and how our interventions will define whether they will succeed or not. To get to hydroxychloroquine, as you know, was used originally in malaria and now is used for lupus and so on because of its ability to alter the immune response. I think, it got a lot of traction because of early data from poorly designed studies in China and in France, and then became political football with people punting it when it really didn't have an evidence base. I think the evidence is now pretty compelling enough that the WHO dropped it from the Solidarity trial. And so in South Africa, there were 3 trials underway with hydroxychloroquine. All of them have been stopped because the evidence is pretty compelling that it doesn't help.
And I think as we begin to close, one last comment, and I think there's been a lot about herd immunity, and we know that there are probably many people, I think if you've alluded to that, walking around who might be asymptomatic and never showing symptoms, or pre-symptomatic and being infectious. I think it's important to perhaps have a good definition of herd immunity, and certain countries employed it, perhaps not correctly so, but I'd like to hear, I think it would be great to hear your comments on that, on what herd immunity is and how it should effectively be applied.
Sure. I think there are 3 fundamental problems with trying to achieve herd immunity. Herd immunity as a strategy has 3 fundamental problems. The first is we have no idea whether natural disease and natural infection leads to protective immunity. Now, if you have this coronavirus infection once, are you protected from getting it again? That question is unanswered. We have to wait for enough second waves to occur in China and in countries that have had this virus go through the first time. So we don't know whether initial infection leads to lifelong immunity. The second is, even if it does protect, we have no idea how long it will protect for. It could be that it's just short-term protection, in which case the herd immunity won't work for very long if the immunity is short-lived. The third is that we now have a better understanding that some asymptomatic patients in particular have very poor immune responses and do not have immunity that is measurable in antibodies. So it's thought that those with this very mild disease do not respond and create significant humoral immune responses. So you've got three problems. You add to that we have no idea what the herd immunity level is. How many people, what proportion? 30%, 60%, 90%? We have no idea. You can do a simple calculation based on the R0, which will take you to somewhere between 60 and 70% for herd immunity. Okay, so let's say it's 60%. Are we going to wait for 60% of the population to get this disease? You better start creating a lot of graveyards, if that's your plan. And countries that have tried to do this, Sweden most famously, they ended up with the highest death rates in Scandinavia, Sweden. And the most recent survey of antibodies in Stockholm shows that only 7.3% of the population in Stockholm have antibodies. They are nowhere near herd immunity. If they're going to aim for herd immunity, they're going to have a lot more deaths and a lot more infections. So as a strategy, it does not seem to be an appropriate strategy to aim for. If we have a vaccine, that's a completely different story.
And one last question we can squeeze in from somebody is in terms of serological testing, antibody testing, and does South Africa have a rollout of good assays that can look at the serology of pre-symptomatics, asymptomatics, infectious, how long antibodies last for, that sort of thing?
So, we are in desperate need of a good serological test. Our problem is we haven't found one yet. We've had submissions to our regulator that exceed, we have more than 100 different submissions for lab-based high throughput assays, lateral flow assays, antigen assays. They've all been submitted. They've all gone through validation, not good enough. The challenge is on both ends. The first is that the antibodies take a while to develop. So you can't use antibody tests for the first 10, 14 days. It's really after that you can use it. But when you use it after that, the problem is that even if you get sensitivity that's pretty good, the specificity is not high enough. So we're not sure that's the problem. Is that a problem of other coronaviruses cross-reacting or whether it's a general cross-reaction? But because the specificity is not high, in a low prevalence disease, your positives are more likely to be false positives than they're likely to be true positives. And so we haven't really been able to find a test that's good enough, either with high enough sensitivity and high enough specificity. But once we do have a test, and there's certainly newer generations of tests that are now coming into the scene, I'm optimistic that we'll have one. We'll have one pretty soon, because I can tell you we really need one. We need one. For example, I'm investigating outbreaks. And when I get to a situation, it's already been spreading for 4 or 5 weeks. I need antibodies to know who has been exposed. Some people say, well, we'd like to create immunity passports. I'm not a big fan of that. Until we know that immunity protects against subsequent exposure and infection, and we know its long-lasting effects, I would be very hesitant to treat anything with any situation of antibodies, with conflating that with immunity and immune passports. But as a serological assay, we need to understand the epidemiology of this disease, and we need a good antibody test for that.
Yeah. Slim, thank you very much. This has been a wonderful session, a wonderful talk, and a great discussion. Thank you all very much for listening and posing your questions to Slim. I've tried my best to respond and integrate many of them into questions. So thank you again, Slim, and thank you all very much. And I think this session is now over. Thank you.